to try to give you the main concepts of the Transpterygoid approach and how we use it. Then after that, you can try to adapt it to your own like. So the Transpterygoid approach is probably a misnomer, and it's a source of confusion because people don't know what the heck you're talking about when you're talking about the Transpterygoid. So the truth is that it basically is as simple as it sounds. You're going through the pterygoid process on a Transpterygoid approach. So why would you need that? Well, you already heard, Danny, you have to go through part of the pterygoid process to get to Meckel's cave. You have to go through part of the pterygoid process to get to the nasopharynx, to get to the infratemporal fossa, middle cranial fossa, and lateral recess of the sphenoid. So all those are Transpterygoid approaches, but I'll tell you how it varies from one to the other. The importance of that is that it's a real state that is very small, but it has a lot of critical structures on it, and it's really easy to get confused. So when we look at the anterior skull, especially from endoscopic standpoint, you're going to go through the nasal cavity, and you will get to the back of the sphenoid, and this is basically what we see with a sinonasal corridor. So you have the palatine bone, you have the sphenoid bone on the back, and basically you see the rostrum of the sphenoid. But you see that most of the pterygoid process is really hidden by the palatine bone, the pterygomaxillary fossa or pterygopalatine fossa, and the maxillary sinus. So all you see through the nose is really the rostrum of the sphenoid sinus. Now, if we get to the sphenoid bone, I want to call your attention to these two landmarks. That's the Vidiian foramen and the foramen rotundum, color-coded for you. And those are going to become the two main points for navigation. So aside from that, I always have in mind that the sphenoid, the rostrum of the sphenoid makes a kind of an H, or rugby goalpost, if you want to go that way, with the pterygoid plates. So the medial pterygoid plates is the lateral aspect of the posterior choana. So when you're looking at the posterior choana, what you're looking is really the medial pterygoid plate. So obviously the eustachian tube and the torus tubarius is right behind it. So coined the term, you can see it here, it's not anatomy, it's aminatomy, of pterygoid wedge. Also a term that you're not going to find in any anatomical book because it's a surgical landmark. And basically what that means is that we have a wedge-shaped area here, that the most superior and lateral aspect of that wedge is basically the Vidiian foramen. But you won't see the Vidiian foramen through the nose. You really have to go into the pterygopalatine fossa to see it. Now, the palatine bone, I want you to dwell on it a little bit because it's really an important bone. You see, what we see as part of the lateral nasal wall is really the ascending process. That ascending process has a little notch that we know as the sphenopalatine foramen. So it has an orbital process, a pterygoid process, and the sphenopalatine that is going to become another landmark as we go along on the talk. So again, people get confused. We got confused at the very beginning of our career because in the lateral aspect of your rostrum, in the inferolateral aspect, you see a little artery sometimes, and you see something that looks like a foramen. And we thought it was a Vidiian, it's not. It's really the palatovaginal fissure with the pharyngeal artery. So if you see something that looks like a foramen through the nose, you're probably looking at that and see that it is formed by this flare that the pterygoid process of the palatine bone has when it joins the sphenoid. Oh, that's not good. Ay, ay, ay. Okay. Let's see. A lot of IT issues here. Sorry, I'm going to have to restart this. So any questions? Okay, let's restart it. It will probably work. Are you saying you shouldn't go there? So the problem with technology is when you have a failure, you have a big failure.
Rick,
yes? Yeah, so that's a good question. We're going to be talking about dividing the Vidiian nerve and what the consequences of doing that is. For most patients, it's not really a whole lot. If your patient doesn't have a dry eye to begin with, that patient is not going to complain to you of anything after the surgery. However, if you ask the patient with more detail, they will tell you that when they cry less on the eye that you cut the Vidiian. Now, that's only a simple sacrifice of the Vidiian. If you happen to accentuate the pterygopalatine fossa, like we do in some cases with a nasopharyngectomy, that patient is going to have a dry eye. So they have to be some other little branches that exist there in the pterygopalatine fossa that go also to the lacrimal system, and they take care of part of that. But if you take them all out, they will have a dry eye on that side. Now, if you have a patient that starts with a dry eye, that they have it already, that patient is going to have a much drier eye at the end of the resection. So meaning that if you have a patient that has a 7th or a V1 deficit, those patients may be at risk for having chronic problems from taking the Vidiian. So if you have an alternative approach, that would be better than having to sacrifice the Vidiian.
Can you comment about the palatal canal and when you manipulate it, people have numbness on the front of the teeth and their...
That's really not the palatovaginal, but the lesser palatine foramen. You can do it for the greater palatine nerve. You can manipulate it. If you manipulate it, they usually have numbness. We see that when we raise the nasoseptal flap because the nasopalatine nerve gets affected. That also goes to the two front teeth, and they do complain of that. Usually it's temporary. I think I have seen it permanently in one or two patients, but it's usually just a temporary issue. At the very least, the patients forget about it. They learn to live with it. They don't complain about it anymore. So as I was mentioning before, to get to the pterygoid process, you have to go through the pterygopalatine fossa. The main landmark that you're going to get to the pterygopalatine fossa is the sphenopalatine foramen. We'll talk about that in a second. But if you look at the pterygopalatine fossa, it's a very small space, and it's really shaped like an eccentric pyramid, inverted, as you can see here. And what you have to remember about it is that it has two compartments, an anterior compartment that has vessels and a posterior compartment that has all the nerves. So this is kind of lucky from the surgery standpoint, because they can control the vessels without hurting the nerves in most instances. So you can see here, we're looking at the left side, illustrating the same point in this schematic. And what I want to show you is that this sphenopalatine ganglion that is behind the vessels has 3 branches. One goes to V2. That one you can forget about. Basically, you can sacrifice it. Won't have any major deal. And you have the Vidiian that goes away, and you have the greater palatine nerve that goes down into the palate, and also a lesser palatine. So here you have in the schematic the same deal after you mobilize the artery, and here you have it in the cadaver. And I want to mention the infraorbital nerve and infraorbital canal, because from the endoscopic standpoint, it becomes a great landmark, because once you cross the infraorbital canal laterally, you know that you have crossed into the infratemporal fossa. If you're medial to the canal, you're in the pterygopalatine fossa. So it gives you an idea on the direction and the extent that you're going. Also, if you can draw a line, the vertical line that crosses the canal, basically all the branches of the internal maxillary artery are going to be medial to that. So in other words, the internal maxillary artery divides in all the branches more or less either lateral to that line or at that line. So if you are lateral to that line, all you need to do is look for one big trunk, and you will control the entire system. So if you look from the outside, you look from the infratemporal fossa to the pterygopalatine fossa, you will see this fissure here, which is the entrance to the pterygopalatine fossa. That's called the pterygomaxillary fissure. If you look from the inferior to superior, you can see that pterygomaxillary fissure is continuous with the inferior orbital fissure. They form kind of a half moon. Inside the orbit, that inferior orbital fissure is very close to the superior orbital fissure. So if you have that in mind, you can kind of
predict how many tumors can go from one space to the other. How can they can get from the nose to the pterygopalatine fossa to the infratemporal fossa to the orbit and up into the cranial cavity into Meckel's cave or the middle cranial fossa. So let's just keep through that. So from the practical standpoint, if you can throw vertical and horizontal lines on those two foramina that I showed you before, with the vertical lines, they are going to divide the spaces in sinonasal tract, infratemporal fossa, and in between, is going to be your pterygopalatine fossa, more or less. It just gives you a good idea. The horizontal lines then further divide those spaces. Here above the Vidiian canal is going to be a sphenoid. This is going to be the lateral recess of the sphenoid sinus in between the rotundum and the Vidiian, and middle cranial fossa is going to be on top. How does that help you? If you can identify the two foramina on an X-ray and you see the relationship of the lesion to those two foramina, you will determine how much of an approach you need. And what I mean by this is this. So if you have anything that is inferior to the Vidiian canal, as we're showing here, you will need a medial maxillectomy, meaning that you have to remove all the lateral wall of the nose. If the lesion is at the level of the Vidiian or above, all you need is a nasoantral window. So it's going to be a wide nasoantral window, but that's enough. If you have the lesion is medial to the foramen rotundum, all you need to expose is the back wall of the antrum. If it is lateral to the foramen rotundum, you're going to have to remove the lateral wall of the antrum, which is actually difficult to do with a simple medial maxillectomy. So I'm going to show you later how to get there. So again, you have to find, this is the direction that you're going to come. This is an axial view, maxillary sinus, pterygoid plate, pterygopalatine fossa, a sphenopalatine foramen. You can see that the sphenopalatine foramen is immediately posterior to the posterior wall of the maxillary sinus. If you look at the sagittal view, you can see that that foramen is in the superior third of the height of the posterior wall of the maxillary sinus. So if you can look at the posterior wall of the maxillary sinus, you get those two coordinates. It's going to be immediately posterior and at the superior height. So that's how we find the foramen in most cases. I'll show you some other landmarks that will help. This is just an editorial comment. We talk about the sphenopalatine foramen, we talk about the sphenopalatine artery like they were single entities. They are not. Okay? You have to think that there are at least two major arteries coming out of there, the sphenopalatine and the posterior nasal, at least two. And they can divide proximal to the foramen and they can divide distal to the foramen, meaning in the nose or before. And not only that, but you can see here that in most of us, there are actually more than two branches. There are at least three branches. And a significant portion of us, at least in a third, you're going to have four branches. And you can have more than one foramen. So the exception really becomes the rule. Here you have an example. We're on the right side. This is maxillary sinus over here. And you have 1, 2, 3, 4, 5, 6, at least 7. And coming from multiple foramina. Just have that in mind, that as you're looking for it, don't get surprised by seeing multiple foramina and multiple vessels coming out of it. How do we do it? So here again on the left side, middle turbinate, posterior wall of the antrum over here. You make a very wide and extensive nasoantral window that extends from the inferior turbinate to the inferior wall of the orbit. You take it back until you are flush with the posterior wall of the antrum. Then you elevate that mucosa that is just medial to the antrum and posterior to it, and you are very likely to find the foramen. Other landmarks, in all of us, you're going to have a little bit of a spur of bone that's called the crista ethmoidalis, and it can be small, it can be big, but it's present in everybody. And that basically marks the anterior aspect of the sphenopalatine foramen. Now look in the wall here. Do you see this kind of canal at the posterior wall? That is present in 40%, 50% of everybody. And basically it marks how it is formed by the internal maxillary artery as it comes in the terminal branch toward the foramen. So if you follow all those, the coordinates that I told you before, the crista and the protuberance, you will find the artery. And then what you're going to do is you're going to remove the back wall of the antrum, kind of exposing the entire pterygopalatine fossa. You want to be subperiosteal, meaning that the periosteum that is behind the posterior wall of the antrum is better preserved. If you don't preserve it, if you hurt it, you're going to get into bleeding. You're going to get into the pterygopalatine plexus. Not a big deal, but it's a 15 to 30 minutes penalty. You have to take care of it. And it's going to become more tedious. So if you preserve the periosteum, you're going to be completely avascular when you do that. Then you're going to also preserve the periosteum in front of the pterygoid plates. So if you do that, then all the soft tissue contents of your pterygopalatine fossa are in that little sac of periosteum, and you get no bleeding, and you get your foramina much easier. It's much easier to identify the foramina. How we use that? Well, let me give you a couple of examples. Here's a CSF leak in the lateral recess of the sphenoid. How do we get there? We do a sphenoidotomy in the usual way. We do an isoantral window in the usual way. We find the sphenopalatine artery and expose the pterygopalatine fossa. Then you can sacrifice that posterior vessel. That is the same vessel that supplies the flap. And by doing that, then you can extend your sphenoidotomy laterally. Now, a couple of little tricks with this. If you have a Vidiian canal that is flush with the floor of the lateral recess of the sphenoid, it's going to be a very easy case. Why? Because you don't have to worry about the pterygopalatine fossa. You can leave it in place. You don't have to mobilize it. You don't have to sacrifice the Vidiian to get to that lesion. Now, if the Vidiian is higher, then it's going to get in your way as you come this way, and you're going to have to sacrifice it. So let me skip through some of this. This is a case where on the left side, we have done our sphenoidotomy. This is the pterygoid wedge. This is that flare of the ascending process of the palatine bone. And you can see the artery going on the palatovaginal canal. Okay? So the palatovaginal canal, the artery goes in there and comes out there at the posterior choana. So we just sacrifice it. Dan, actually, we did this case here. This is our case with Amin. We did this case together here in Santa Monica. So here is here is the extension to the lateral recess, and now we're extending our sphenoidotomy laterally, and we're actually trying to preserve the Vidiian, but in this case it had been operated before, and we had to sacrifice it because it wasn't really dissecting the way we wanted. If not for the fibrosis, we would have been able to spare the Vidiian. At the end, this is what we have. We're looking at all times with a 0-degree scope. And you can look at this with an angle scope in an easier way. But if you have to look with an angle scope, that means that you have to work with an angle instrument, and it becomes more difficult. Okay. So at the end, we're looking with a 0-degree scope, meaning that we have a straight instruments. You can see the encephaloscope, and then you can repair it in whichever way you want. I'm not going to dwell too much on the technique. Just whatever you want. Now, once you start thinking about going further back or further lateral, you have to think about the carotid at all times. You have to think carotid. And then you have to think, do I have the skills to get there? You have to really think about this. Do you really want to get there? Do I have the temperament to deal with a carotid injury? So this is what I call a double patch surgery, and this is for the surgeon, not really for the patient. Testosterone patch and nitroglycerin patch always helps. You also have to have in mind, this is when having a bidimensional view really gets on your way. Okay? Why? Because the 3 dimensions of the carotid is very complex. So we all know all the turns and curves. So it comes up, it goes from lateral to medial, and at the same time goes from posterior to anterior, and then goes up and forms the siphon. And guess what? When you look at it in a bidimensional way, you don't see any of that. So you have to have it in mind. Even when you're using a navigation, you have to predict how the carotid is going to move. Otherwise, you can get in trouble. How can you get in trouble? Well, this siphon over here is 2 centimeters anterior than the paraclival. So you think that you're moving in the same plane, you're looking at the paraclival because it's very visible, and you don't see that anterior genu coming up, and you're thinking that you're far away. All of a sudden, you have a very red monitor. So we have developed other landmarks for the carotid artery. Dan, let me know when I have 3 minutes left or something. I can stop at any time. So we have developed some landmarks for the carotid. We have talked about some of them. So for the paraclival carotid, you have the posterior choana. The posterior choana, I told you that the lateral wall of the posterior choana is the medial pterygoid plate. And you can see here the paraclival, you have your medial pterygoid plate. You can see that they are in alignment. When you have a case like this, obviously, it's not that useful because you can see all the landmarks. But if you have a tumor that is on your way, you know that if you don't cross that plane of the choana laterally, you don't have to be worrying about the petrous carotid. Okay? If you stay medial to it, you're going to be okay. So it may accelerate your surgery. For the horizontal or petrous carotid, we have the Vidiian nerve. We have talked about that before. So here we have a complex schematic. We are on the right side, parapharyngeal, petrous, paraclival. We see that the Vidiian nerve is going to go on top of the petrous and lateral to the paraclival. If you have an artery, it's going to go more or less at the transition of the two. But look at this other structure we have here, V2. V2 is going to go to the gasserian. Where is the gasserian? Same. It's going to be on top of the petrous, lateral to the petrous, lateral to the paraclival. So the gasserian is going to sandwich that Vidiian nerve in between the ganglion and the petrous carotid artery. Now, this bone in between them is going to be a wedge-shaped bone because they're coming to the same place, right? So the tip, the bone is much smaller here or narrower there than what is here. So it's kind of a pyramidal-shaped bone. So the tip of that bone is going to point to the paraclival. So we don't use one landmark. We use multiple landmarks that we're triangulating to make sure that we get to the right place. And Danny, did you mention the fascia, the basopharyngeal fascia? We also use the basopharyngeal fascia from the nasopharynx because it gives you the impression that it goes up. And when it goes up, that marks the foramen lacerum, basically. So relationship of the sinopalatine artery coming up with the Vidiian, you can see it's more or less at a 90 degrees. You can see it in the bone, in the skull, and you can see it in the X-rays, and you can see it in vivo. So here we have a dissection on the right side, paraclival carotid, petrous carotid, gasserian ganglion, V2. Here is the artery, the Vidiian artery. So here's the Vidiian at the junction between the petrous and the paraclival. I don't see the nerve in there, but you know that it has to be somewhere here. On the other side, same type of deal, paraclival, petrous, and you have the gasserian ganglion, and the Vidiian nerve is over here, sandwiched in between the two. So just remember that relationship. Danny talked about that. Remember also the landmarks that we have from open skull base. So we have lateral pterygoid plate. It's an alignment with the foramen ovale. It's an alignment with the espinosum. So you can throw a line on those. You can throw a line on those, and you know that if you are lateral to that line, you don't have to worry about the carotid. The carotid is going to be medial to that line. But also from the endoscopic standpoint, the lateral pterygoid plate, you can throw a line with the foramen ovale or V3 and the carotid canal. They are many times they are in line, so that becomes also a landmark. So if you can preserve your lateral pterygoid plate, many times that will give you a kind of a goalpost that you cannot cross. At least in the sagittal plane, it's going to be aligned with that carotid. And of course, that has a lot of exceptions, but you will be able to see it in your X-ray. So here, the carotids are a little bit more medial than the plate, and here they are right on the spot. And you remember that carotid can be ectatic and can have turns and deal, and all this may fail you, but you should be able to ascertain that from the X-rays. So other landmarks that we have, eustachian tube. So the eustachian tube, you can see here that it's a little bit anterior and medial to the carotid canal. So the eustachian tube becomes both a guardian of the parapharyngeal carotid and the canal, and also a landmark, because if you follow eustachian tube up, it will take you to the canal. Okay, petrous carotid is going to be also behind it. So eustachian tube is your guardian. So we're looking at a kind of a 45-degree angle, so you can see all the structures, but as you move from anterior to posterior, we have removed the pterygoid process. Here's foramen, we have removed the skull around foramen ovale. You have V3, eustachian tube, petrous carotid in the back. Where is going to be parapharyngeal carotid? It's going to be behind the V3, behind the eustachian tube, but at the same sagittal level of V3. So it should be here. So let me skip through some of these things to get to the other ones. 3 more minutes. Perfect. I just want to get to this. These are two nasopharyngeal tumors. What happens, how to get to these tumors, because you need an oncologic resection, so you have to go more lateral. The tumor on there are two different patients. So the tumor on the left, you can see here that I can obtain an oncologic resection by doing a medial maxillectomy, going through the pterygopalatine fossa, going through the pterygoid plates, the eustachian tube, and that takes care of the fossa of Rosenmuller. I'm done with that one. Now, if I use the same thing on here, you can see that tumor goes a little bit more lateral. So that will fail me. How do I get there? Well, I need to increase the angle, and the way to increase the angle is to really come and do a Denker's approach. The Denker's approach is the removal of the piriform aperture and removal of the anterior maxilla. And if you have a European education, you will call it the Sterman-Canfield approach. It's really the same thing. Okay, they're talking about the same removal of tumor done through different techniques. So here is how it works. We're looking at the right side. That's what you see with a medial maxillectomy. That's with a 0 degree. And yes, you can look better with an angle, and you can come from the other side and get the angle. But basically, with a 0 degree scope, what you have control is the back wall of the antrum. So once you do your Denkers, you have removed your piriform aperture, and do an anterior maxillotomy. Now you have control of all the walls of the antrum, of the lateral wall, and that gives you an incredible angle laterally. So let's see how it's done on the contralateral side. So here you have is an incision at the level of the piriform aperture that's anterior to the inferior turbinate. You go subperiosteal and you elevate subperiosteally. You can see here we're preserving the periosteum. That was the inferior orbital nerve coming out in there, and you can get basically expose the entire zygoma. Now we have done the maxillotomy, and we have the nasal cavity, and in between is the lateral nasal wall with the lacrimal apparatus that is going to be removed. So in this case, we're going to do a marsupialization of the lacrimal sac. That's what we have here. So we don't have any problems with epiphora after the surgery, but you see that through the nose, we have full control of the lateral wall of the sinus, where that allows us to get into infratemporal fossa better. So this is an extradural resection. Here you have carotid artery in the back, sella, and you have the Gasserian ganglion on the side. Let's see, it's going so slow. V2, V3, there's no bone in between. The dura has been preserved. This is a case of a recurrent osteosarcoma coming from the maxillary sinus, and there what we're showing, that's foramen spinosum right there with middle meningeal that has been exposed. So here is before the surgery, after the surgery, that patient remains alive. Just a little warning, the Denker's approach, you do take a little bit of support for the nasal cavity, and you can have this type of alar retraction, especially in patients that required proton therapy after surgery or radiation therapy after surgery. So I don't do it in adolescents or children. I think we can stop there. Or just a little case here. So just to remind you that this transnasal approach is not the only minimal invasive approach. Just like neurosurgery have your mini craniotomies and your other little approaches, we also have in ENT other ways of getting there. So this I'm going to show you a transoral approach. This is a chondrosarcoma that I removed with Danny, and that chondrosarcoma was following the jugular, the jug, basically. It was following the carotid sheath down. So it's below the level of the hard palate. So there are many, how would you get here? I mean, most people that I ask, they come from a lateral approach, which is okay. That's what most head and neck surgeons would do. But what we decided is just do a transoral hyperpharyngeal approach. So you can see here, it's at the level of the palate, level of the anterior pillar of the tonsil, and doing that, you get to the hyperpharyngeal space and get to the tumor, remove the tumor in the same way that you removed it, and you have much less chance of sitting along a very long corridor like a lateral approach. This took 35 minutes instead of hours. So I'll stop here. I hope that if you were confused before, at least you're still confused at a higher level than what you were. Thank you.